Happy Sunday, it's Dr. Soloway. Very humbled and happy to give today's presentation to Emily from Suffolk County, Long Island, who is a longtime friend and faithful patient who drives 3.5 hours each way to come and get injections for osteoarthritis. Emily had gone to orthopedic surgeons originally thinking that bone problems were treated by orthopedic surgeons, not realizing that orthopedic surgeons are for bone or joint surgery if something has to be replaced or repaired, while rheumatologists design treatment plans that include, on various occasions for various reasons, splints and braces, physical therapy, occupational therapy, correct diagnosis, correct treatment for the specific diagnosis, as there are more than one type of arthritis, various pills, which pills would be correct, which pills would be incorrect. So Emily had several questions. So the first visit years ago was, my thumbs are killing me, I can't move them, I'm having trouble working as an accountant, I can't type, and life is just really not fun. What can you do for me? So history, take questions, physical, examine the patient, come up with a conclusion that the patient has osteoarthritis. And Emily, this is where I start to answer your questions as well as give generic but specific but generic answers. And I want to try and cover your questions all in one summary. Questions are basically, is it inevitable that your arthritis will get worse? Is there a cure to arthritis? What about the people that develop arthritis when they're younger, like in their 20s? And what about the eventual need for physical therapy or surgery? These are really perfect questions for yourself and for any other subscribers to my YouTube channel. And if you're not a subscriber, please subscribe to Stephen Soloway, MD, and this will give you the opportunity to ask questions as Emily did and get personalized one-on-one responses. So first, by the age of 40, we all have, for reasons that are not purely understood, we have thinning of cartilage. And there are some genetic factors and there are some environmental factors. Again, poorly understood. We know there's genetic factors because it runs in families. Now, when we talk about arthritis at age 40 and beyond, while this is not set in stone, we are talking about osteoarthritis. That doesn't mean somebody that 50, 60, 70, 80, or even 90 can develop rheumatoid arthritis. But on the streets, the quote, good arthritis is osteoarthritis, and that's the type of arthritis people get from aging in the generic sense. So when you're faced with somebody who has a painful joint, you have to make a decision based on your history, physical, and whatever else you need to do, whether it's x-rays or drainage of fluid. You need to come up with a diagnosis. So in Emily's case, the diagnosis is osteoarthritis, and 2 to 3 times a year, Emily drives 3.5 hours each way to have injections in various parts of her thumb. The relief is 100%, and it lasts for anywhere from 3 to 6 months. I've had cases where it lasts much longer, and I've had cases where it doesn't work at all. There are reasons why it wouldn't work at all. There are reasons that are not understood, and I don't understand them either, why the injection may last what seems like indefinitely or even years. And if a shot's going to last for years, it probably means the arthritis really isn't that bad. It's never been tended to before, and the injection put it back to normal, essentially resetting its thermostat. And when I say normal, we didn't make the arthritis go away, but whatever the issue was that was causing the pain on that particular occasion, whether it was an inflamed nerve in the joint, whether there was a small fracture that eventually healed, or whatever it was. We reset the reset button and the pain went away. So the question is, you're asking, is this going to go on forever? Is it inevitable that I get worse? Well, keep in mind, you're in your 50s, and you didn't become symptomatic until you were probably 45. So it took from birth until age 18 to develop your bone structure and your joints. And then it took from age 19 till 45 to be free and easy and careless to allow yourself to damage your joints, whether it was too much typing or too much writing. Now, if you're genetically predisposed, you're going to get it anyway. If you're not genetically predisposed, then these things will occur, to your joints. So in a runner, they may get arthritic knees. In a skier, they may get arthritic hips. In anybody, they may get arthritis in their back. In a white-collar worker, they may get problems with their fingers. The most important finger for functionality is the thumb. So you have issues with your thumb. I take a needle using my own technique that I've taught myself to do. And frankly, the reason that you ended up coming to me is because nobody between anywhere and any other spot can inject your thumbs with less pain than I do and get better results. Those that go to hand surgeons, they'll get a shot. It's not as accurate as mine, so accuracy matters. The amount of medication matters. The placement, the whole technique matters. It's like baseball players. They might all be professionals, but they all have a different batting average. And when it comes to this type of medicine, which I would call medical orthopedics or just osteoarthritis, but the general public doesn't know it by that name, and they think all of these problems would go to orthopedics, where they conveniently give one shot or two that doesn't work, and it's predictable that they don't work. And I've done this for 27 years. I know they don't work. They offer surgery in the fashion of a joint replacement. Now, yes, you can get your knuckles replaced anytime you want, just like you can have plastic surgery to your face anytime you want. This is sort of optional. So regarding osteoarthritic pain, one, will it get worse? So it took you decades to get to where you are, and it will take you decades to get worse. Now, when you're 90 years old, yes, it may be worse than it is. Does that mean these shots will no longer work? I'm not really sure. I've seen all scenarios. I've seen scenarios where they don't work on the first occasion. I've seen occasions where they work not the first time, but they work on the second occasion. I've seen them last years, weeks, months, any situation. But the reason we're flooded with follow-ups and people begging, to see if they qualify for an injection of a joint is because the success rate is very high. Higher with me than anyone else. Why that is, perhaps my passion for it, my patenting of needles for it, and my understanding of it is better than other people. That's just my speculation. Everyone has their fortes, and I'm blessed. Everything in the field is my forte. So that was meant to be a little bit of a dry joke, but but like any other joke, there is a little truth to it. I was trained by wonderful people, brilliant people. The ones that are living, I still have a great relationship with. And at this point, I think for the most part, they look at me as sort of a pioneer in my own right. So, is there a cure? No, there's absolutely not a cure. Don't let anyone tell you there is a cure. There's nothing on QVC. There's nothing on Facebook, eBay, YouTube, whatever. There's nothing. There's no cure. So the standard of care would dictate that for a young, healthy person like yourself, under 65, you should be taking 1,000 milligrams of Tylenol 4 times a day. And if that works, then that's the end of the story. If it doesn't work, then under 65, it's okay to add an NSAID or non-steroidal anti-inflammatory drug This can be something simple like Aleve, Advil, Motrin, ibuprofen, and frankly, they're all the same. And frankly, there's about 25 or 30 that are currently on the market and can be received by prescription. Some can be received over the counter. I believe Ketorolac is another one, and some forms of Voltaren can also be obtained over the counter. But nonetheless, they're all the same in one way or another, although the Voltaren products tend to cause a little more hepatitis or liver inflammation than the others. Have to be careful about what the dosing is, but again, under 65 years old, it's comfortable for me to tell you it's okay to take the maximum dose. The reasons that we don't use it much, or that I don't use it much past age 65, is taking that medication blocks an enzyme called prostaglandin, and by blocking that, it thins the lining of the stomach, making you prone to get stomach ulcers. You don't want stomach ulcers. That creates a whole new set of problems which could have been avoided by using Tylenol and having the joint injection. You can also retain fluid, get high blood pressure. You can have blood thinning. It's very difficult. When you get older, you get more health problems. You're often on other medications. You don't want to combine the NSAID products with the anticoagulants because the risk of bleeding goes up very high. So osteoarthritis can be crippling and debilitating. However, it's not the crippling or debilitating type as you would know it on the street. So osteoarthritis, which is what you have, or which is when people get what looks like extra bone growth in their knuckles or their knees or their lower back or the base of the thumb where it meets the wrist. These are the most common joints that we wear out, again, genetically or environmental. So joint injections present a great option. In the right hands, they're very safe. The risk of infection is less than 1 in a million. And that's if you probably don't even clean the joint, it's probably less than 1 in a million. But studies show 1 in a million would be to aspirate and inject a knee. So your joints are small, they're hard to aspirate. I would only aspirate them if they were red, swollen, tender, and I was looking to make sure there was an infection or trying to confirm that there was a crystal. A crystal, just like it sounds, is like a salt, and you can see it under a microscope. The most common crystal is gout or monosodium urate. The next most common crystal is pseudogout, or what is also known as calcium pyrophosphate deposition disease, or calcium pyrophosphate crystal. And the next most common, which is not very common, but it's seen in my practice with regularity, is hydroxyapatite deposition, or basic calcium phosphate crystals. Those are recognizable, but not guaranteed identifiable without a special stain. But nonetheless, in the right hands, the diagnosis is not that hard to make. So when these diagnoses are made, we have to ask ourselves, are there any other associated conditions that go with them? We have to address those with or without the family doctor. You know, it depends how many other problems are going on. But regarding the injections, think about this. If you have a joint that's worn out, you have the option to get it replaced. And if it's replaced, there's a chance that it'll get better and look wonderful. No different than pulling one tooth out and putting in an implant. Although I think the implant route has better success than joint replacements to a large degree, especially when it comes to fingers. So surgery is always the last resort, but it is a viable option in somebody who's completely crippled and disabled, and they have an inflammatory process as opposed to osteoarthritis, which we generically consider non-inflammatory, albeit that said, cell count in non-inflammatory diseases like OA or osteoarthritis is still considered to be normal or uninflamed with a cell count of 2,000, which is clearly above the upper limit of what would be considered to be totally normal. So we do know that there's some component of inflammation even in the non-inflammatory arthritis. If this is confusing you, trust me, it's confusing for me to tell you. And if I need to clarify more, you'll tell me and I'll try to answer it more directly or with more care to the answer. So surgery is not inevitable. Surgery is more of your choice. If the shots don't work, and the reason I give the shots is they're safer than taking anything by mouth. And even if you're a diabetic and the sugars were to go up, you'd know in advance that your sugars are going to go up for 5 days after the shot. And the amount your sugars go up depends on your control of your diabetes. So if your hemoglobin A1C were well controlled, you don't really need to worry about your sugars going crazy. But if your hemoglobin A1C should be 5 and it's 10, your sugar is going to shoot through the roof, possibly landing you in the hospital. So that's where the caution comes in. Historically, the risk of getting a needle under your skin is infection, bleeding, and pain. In reality, if the user of the needle knows what they're doing, the risk of infection, bleeding, and pain, never say never, never say always, but in my hands is virtually zero. If I happen to have caused one infection in 31 years, which includes my training, then that would be about it. Anything's possible, but doing tens and hundreds of thousands and millions of injections over all these decades, I can assure you that they're safe, and you as the patient, you already know they're safe. You know what pain level there is and how long the pain lasts, and you know how long your relief lasts. So that goes to, what's the risk-benefit ratio? Well, the risk is you can have those things I mentioned, and the benefit is you can get pain relief for, in your case, it sounds like about 3 months or so. So can you have these injections every 3 months for the next 40 years? The answer is yes, you can. But I would say you should be on the Tylenol if you're not, and I would try an NSAID product until you're 65 in the lowest, most effective dose. There's no right dose. There's the dose that works for you as long as it's dosed properly, not leading you to side effects. And side effects can occur from the intrinsic property of the drug or because of drug interactions. Okay, let me just check my sheet to see if I've answered everything. So young people with arthritis, children, teenagers, 20 and 30-year-olds that get arthritis, you say, gosh, I thought you needed to be old to get arthritis. Well, you need to get old to wear out your joints, but you don't need to be old to have your joints inflamed, any different than you don't need to be old to get cancer, you don't need to be old to be infected, and you don't need to be old to have a condition that causes inflammation of the joints, whether it's rheumatoid arthritis, psoriatic arthritis, gouty arthritis, sarcoid arthritis, ankylosing spondylitis, infectious arthritis, whether it be Lyme, hepatitis C, HIV, and the other list of 100 and some odd diseases that we look for and find on a regular basis. Those all occur in younger people. Diseases of blood vessels, diseases of lungs, diseases of other organs, when they involve the whole body, the joints are often involved in various patterns specific for each disease. And that will often let the rheumatologist who sees the pattern identify the disease prior to the specialist who will ultimately help treat that disease. No different than if I drain a knee after somebody's been injured. I have found gout crystals, proving that nothing was broken or damaged. I've also found lipid or fat, finding a fracture prior to an x-ray and prior to the patient ever seeing an emergency room or an orthopedic surgeon. And with a fracture, of course, I'd have to have orthopedic surgery involved because I don't treat fractures other than spinal fractures, which are related to osteoporosis. Physical therapy should always be used if possible, but it doesn't work for everybody. In the fingers, occupational therapy can actually not only give you a splint to help take pressure off your joints, but they can customize them for you. The other thing about therapy is the muscle strengthening. So muscle strengthening around a joint is the best way to take the pressure off the joint. So the stronger the muscles are around the joint, which can be achieved with isometrics or not moving the joint, is probably the best way to protect yourself from damage, in the sense that even though nothing will stop the process, you can help alleviate some of the speed of the progression. And again, while there's no cure, if you take some of the weight-bearing load off any joint, you're going to protect it. And whether you do that with a splint or brace or with isometric exercises, then I think you've done yourself a great service. I know this tended to be wordy, but I hope I was able to address, is it inevitable to be worse? Is there a cure, which there's not? Does it develop in children or adolescents or 20-year-olds? It does, but that's the bad kind, or the inflammation, as opposed to the wear and tear. And the eventual need for physical therapy is reasonably common, and the eventual need for surgery is in the hands of the doctor. So I look at my job as a general contractor of joints, and if I can no longer help somebody, I'll refer them to an orthopedic surgeon who specializes in the replacement of that particular part of their body. And under those circumstances, the surgeons that I use get very outstanding results, and patients, even though some don't do well, most do very well and have great outcomes and live normal lives. All right, so if I left anything out, I'm sure you'll let me know. Thank you and have a great day. Bye.